All right, if you're a medical trainee, this is one of those conditions you absolutely have to know. We're talking about mitral valve prolapse. And trust me, this isn't just about passing your exams. You are going to see this on the wards. So let's break it all down.
So let's just start with one number, 2%. What's that? Well, that's roughly how many people in the general U.S. population have mitral valve prolapse. The big takeaway here is that this is not some rare, obscure condition you only read about in textbooks. It's common. And because it's so common, you've got to be ready to spot it and manage it.
So what is mitral valve prolapse really? At its heart, it's a structural problem. When the ventricle squeezes during systole, the mitral valve leaflets, instead of closing tightly, kind of bulge or billow backward into the left atrium. And here is the single most important connection you need to make. MVP is the #1 cause of chronic primary mitral regurgitation. That link between the floppy valve and the leaky valve, that's the whole story.
Okay, first things first. Let's talk about what you're actually going to find when you see a patient. This is all about connecting what's going on inside the heart to what you can hear with your own 2 ears.
Now this right here, this is your classic high-yield boards level stuff. The signature sound is a mid-systolic click. Now this isn't your normal S1 or S2. Think of it as the snap of the chordae tendini, those little heartstrings, as they're suddenly pulled taut by that floppy leaflet billowing back. And right after that click, you'll often hear a late systolic murmur. That is the sound of blood actually leaking or regurgitating back into the atrium. That click-murmur combo is the auditory fingerprint of MVP.
Now, it's also really important to know that not all MVP is the same. There are 2 main patterns you'll see. On one hand, you've got Barlow syndrome, which you tend to see in younger patients. This is where the leaflets themselves are really thick and degenerated. On the other hand, you have fibroelastic deficiency, which is more common in older folks. Here, the problem is often a ruptured cord. One of those heartstrings actually snaps, causing a piece of the valve to just flail uncontrollably. Knowing these 2 helps you understand what the echo report is really telling you.
All right, so you've heard the click, you've heard the murmur. That's step 1. But step 2, and this is huge, is figuring out just how bad the leak is. For that, we turn to imaging. And this is the critical question you have to answer every single time. You know, a patient might have MVP with just a tiny, insignificant bit of regurgitation. Or they could have a torrent of blood flowing the wrong way that's causing serious problems. The only way to know for sure is with an echocardiogram, which lets us put some hard numbers on it. And these are the numbers you absolutely need to burn into your brain. To call primary MR severe, you need to hit these thresholds. We're looking for a vena contracta, that's the narrowest part of the leaky jet, of 0.7 centimeters or more. Or a regurgitant volume of 60 milliliters or more with each beat. And finally, an effective regurgitant orifice area, or EROA, of 0.4 square centimeters or bigger. These aren't just suggestions. These are the objective data points that guide everything we do next. So why do we care so much about those numbers? Because severe MR is a big deal. All that blood leaking backward puts the left ventricle under a state of chronic volume overload. It's constantly handling more blood than it's supposed to, and over time that causes the ventricle to stretch out, to dilate, and eventually to fail. That's the path to heart failure.
Which brings us to the million-dollar question. We know the patient has severe MR. So, when do we actually do something about it? When is it time to send them for surgery?
Luckily, the guidelines are pretty straightforward here. Indication number 1 is easy, symptoms. If your patient with severe MR feels short of breath or fatigue because of it, it's time to operate. But, and this is so important, we don't always wait for symptoms. We also operate on patients with no symptoms if their heart is starting to show signs of damage. And the 2 magic numbers to remember are an ejection fraction that drops to 60% or less, or if the left ventricle gets bigger than 40 millimeters at the end of systole.
Now, when we talk about intervention, the type of surgery really matters, and the guidelines are crystal clear on this. Repair is always preferred over replacement if you can do it. Keeping the patient's own valve tissue just leads to better outcomes in the long run, and what that means for you is that you should be referring these patients to high-volume centers that have surgeons who are experts at complex mitral valve repairs.
But what about your patient who's just too sick or too frail for open-heart surgery? Well, we've got options there too. The main one is transcatheter edge-to-edge repair, or TEER. It's a much less invasive procedure where a clip is guided up through a catheter to basically pinch the leaky parts of the mitral leaflets together. It's a game-changing option for the right patient.
Okay, that was a lot of information. So let's just boil it all down to the absolute must-know high-yield points that you need to walk away with.
So let's lock this in. 1.
MVP is common, and it's the #1 cause of primary MR. 2. On exam, your ears are looking for that classic click and murmur. 3. You need an echo to quantify the severity. Remember those thresholds. 4. You intervene for symptoms, or if you see that LV dysfunction, an EF of 60 or an end systolic dimension of 40. And 5. When you do intervene, you always push for repair over replacement.
And I'll just leave you with this final thought. This field is changing so fast. As these transcatheter options like TEER get even better and safer, you have to wonder, are we going to start intervening even earlier? Maybe before asymptomatic patients show any signs of ventricular failure? That's really the big question facing the future of valve disease. Thanks for tuning in.